Good evening, everyone. So this week we'll continue our series on dermatopathology. We've already covered three reaction patterns, and today we'll discuss psoriasiform reaction pattern, which is a very important and major reaction pattern to learn. Now, essentially, what do we see in psoriasiform reaction pattern is majorly epidermal uh, increased proliferation of the epidermal layers. So you will see that as a biopsy findings of acanthosis or parakeratosis, hypogranulosis, that means the granular layer is not properly formed. You have more of the thickness of the epidermis would increase. Now, why this is happening in psoriasis is because the inflammatory mediators which are there, which are causing the pathology of psoriasis, are releasing different cytokines, which make sure that the epidermis proliferates quickly. And because of this rapid proliferation of epidermal layers, we see those findings on a biopsy. Now, if we want to learn more about psoriasiform reaction pattern, we'll take the prototypic example of psoriasis. Okay, so major part of this lecture would be discussing the biopsy findings of psoriasis, and using that as a template, we'll look at other disorders which show psoriasiform reaction pattern. So, without much further ado, let's start our discussion on psoriasiform reaction pattern. So, this psoriasiform reaction pattern essentially means regular elongation of rete ridges. Okay, so if this is the slide and this is the dermal epidermal junction, this is normal dermal epidermal junction. In psoriasiform hyperplasia or psoriasiform tissue reaction pattern, the retipegs are elongated and it is regularly elongated. So, what do we mean by regular elongation? That means if we draw a line joining the tips of retipegs and the tips of dermal papilla, they are parallel. Okay, so you will essentially see these two lines to be parallel. So this is known as regular elongation, which in biopsy we term as regular acanthosis. Okay, so this is regular acanthosis. So essentially, psoriasiform hyperplasia mean the same thing, regular elongation of retipegs. Now, this was in Weedon's, as per the Weedon's, this is the definition of psoriasiform tissue reaction pattern. There is epidermal hyperplasia. That means apart from having the regular elongation of retipegs and the thickening of the epidermis, this is the epidermis which is thickened, and thickening of the epidermis with regular elongation of retipegs is regular acanthosis. Now, if you go back to the lecture that we had on dermal pathology, and you will understand that acanthosis means thickening of the epidermis. Okay, so the epidermis is thickened, there is regular elongation of the retipegs. Essentially, these two features have to be there for a biopsy to be labeled as psoriasiform hyperplasia. Now, Weedon's used to say, or Weedon's actually says that this is only those two features that you require, but there is a little bit of problem in that. For example, this is an older definition. The newer definition or the newer features which are included along with regular elongation of retipegs are parakeratosis. So you need to have accumulation of nucleated corneocytes in the topmost layer. This is parakeratosis. So that is also required. And parakeratosis clinically is seen as scaling. Okay, so if a disorder has scales on biopsy through the scale area will show parakeratosis. And we know psoriasis is a scaly disorder. So parakeratosis is there. There is dilated papillary dermal capillaries. So the capillaries which are there in the papillary dermal, they are dilated. Okay. Now remember what is psoriasis? It's an autoinflammatory condition. In autoinflammatory condition, the capillaries will get dilated and there will be squirting or there will be migration of inflammatory cells from the dermal capillaries to the epidermis. And this was known as the squirting hypothesis. Right now, it is not followed much, but some people do like to call this squirting hypothesis into question. Why? It looks like the dermal papillae is squirting out some inflammatory mediators, which is forcing the epidermis to grow. So that is what the essentially squirting hypothesis mean. And there is epidermal infiltration of inflammatory cells. So essentially, what do we see in psoriasiform tissue reaction pattern? There is regular elongation of retipegs, there is thickening of the epidermis, there is parakeratosis in the topmost layer, there are dilated capillaries in the papillary dermis, and the epidermal infiltration of epidermal cells. So essentially, these five features should be there to label the slide as showing psoriasiform tissue reaction pattern. So this is a schematic representation of psoriasiform tissue reaction pattern. You will see hyperkeratosis. So look at this layer, okay, stratum corneum layer. It is increased. So it is hyperkeratosis. You will see focal parakeratosis. So this area, the corneocytes have nucleus in them, okay, and that is why that is what is known as parakeratosis, and only a certain part of the keratotic layer is present, is showing parakeratosis. So it is called as focal parakeratosis. That means only in a certain area, okay. Then you have hypogranulosis, okay, hypogranulosis, and this is seen here. So wherever you don't have parakeratosis, uh, this is the normal granular layer. Okay, so here you can see that the corneocytes have little dots in them. Those are granules, and wherever you see focal parakeratosis, below that you will not see the granular layer. So there will be absence of granular layer underneath the parakeratotic layer, which is known as focal hypogranulosis. There is regular acanthosis. That means the epidermis is thickened regularly. That means nearly the retipex have same length, they're elongated. And then you have the dilated capillaries. So here you can see the dilated capillaries. And this are the infiltration of neutrophils. Okay, so you can see bilobed or multiple lobe nucleus. This is essentially showing neutrophils, and these are lymphocytes here. So infiltration by the inflammatory cells. So this is what you normally see in a textbook picture, or you can see a prototypical example of a psoriasiform tissue reaction pattern. Let's move forward. So this is a histomicrograph. I've taken this from Pathology Outlines, a very good resource if you want to learn more about pathology in general and dermatopathology specifically. So here, let's start with the first finding. You could easily see that if you draw a line joining the retipex and the topmost layer of the epidermis, they are nearly parallel, and the epidermis is thickened. Okay, okay. So you can see that the epidermis is thickened. So let me just write it here. So you have acanthosis, thickening of the epidermis, and it is regular. Okay. There is elongation of retipex, and we can easily see that this retipex are elongated. Then you have the dilated capillaries. If you look here, look at this capillary here, dilated. These are dilated. This here is dilated. So the papillodermal capillaries are dilated. Okay. Now let me just remove these markings, and I'll show you the focal parakeratosis in this. Look at this area. This has nucleated corneocytes. Look at this area, nucleated corneocytes. And if you zoom in or if you look closely, you can see nucleated corneocytes here also. So these are the areas of parakeratosis. Okay, so you have parakeratotic path. Additional feature which you should mention always while describing a slide of psoriasis is there is suprapapillary thinning. So can you appreciate that over the dermal papilla, the epidermis is thinned out. It is thinner. While normally it is so thick here, but over the papilla, it is thinner. So this kind of suprapapillary thinning is also a feature which should be mentioned. So suprapapillary thinning. Over the dermal papilla, the epidermis is essentially in multiple areas. You can see that it has thinned out. So that is known as suprapapillary thinning. So that is also a feature in psoriasis. Other than that, you can see perivascular inflammatory infiltrate, lymphocytic infiltrate. That is also there. So slowly by slowly, we'll look at other features in close. We'll closely examine all the other features of psoriasis. So look at this. This is a biopsy showing psoriasiform hyperplasia or psoriasiform tissue reaction pattern. And you can easily appreciate on a 4x scanning view the regular acanthosis. Okay, so you have number one, regular acanthosis. Okay, then you have elongation of retipex. So you can see this elongated retipex. Then you have suprapapillary thinning. Okay, suprapapillary thinning. Let me remove all of these markings. And then you have dilated capillaries. Look at this. These are all dilated capillaries. And then you have parakeratosis. So this is a parakeratotic area. This is a parakeratotic area. So focal parakeratosis is also present. So now you can now I hope that it becomes essentially very clear what all features to look for. So imagine if you see this slide on 4x magnification, and the first thing that comes to your mind or the first feature that you notice is regular acanthosis, you start looking for other features. You start looking for parakeratosis, suprapapillary thinning, and dermal papillaries dilatation. You look at the inflammatory infiltrate going inside the epidermis, regular acanthosis. So look, try to gather as much information from the biopsy as possible, write it down, and then try to connect it. Rather than making a diagnosis on first view, it takes years to master to that level that you can make a diagnosis in just a single view of the slide. So it's better to write down all your observations and then collectively think about it. Let's move forward. So with that introduction, we'll start looking at individual disorders which show psoriasiform reaction pattern. Clear? So let's move forward and start discussing the disorders. So psoriasiform tissue reaction pattern happens from increased mitotic activity of the epidermis. So there is increased mitotic activity of the epidermis. That means the epidermis is now dividing faster. The proliferation of the epidermis is increased, and that is the basic one of the basic pathologies in psoriasis, that the epidermis is dividing faster. Okay, and this faster proliferation or division of epidermis happens because of the you could say because of the inflammatory mediators which are getting squirted or coming out of the dermal papilla. So if you want to, you just go back, and we already have a video on pathology of psoriasis. Just go through it and you will understand what exactly is happening to the skin. The skin, under the action of various inflammatory mediators, starts dividing rapidly. That is the basic simple pathology of psoriasis. Okay. So there's increased mitotic activity, and how do we see this increased mitotic activity? By the elongation of retiridges and by the epidermal hyperplasia and acanthosis. So this increased proliferation of epidermis is seen in a biopsy as acanthosis and elongation of retiridges. Okay. Apart from increased proliferation, you have altered keratinization and this you see as focal parakeratosis, overlying focal hypogranulosis. So these two features show altered keratinization. So there's increased proliferation of epidermis with altered keratinization. These two features are because of release of various mediators from dilated vessels in the papillodermis. We're clear about it, that the dermal vessels are releasing inflammatory mediators leading to epidermal proliferation. Clear? But that doesn't explain why psoriasiform reaction pattern is seen in Lichen simplex chronicus or diseases like Bowen's disease. So what is happening there? In Lichen sclerosis chronicus, Lichen simplex chronicus, Lichen simplex chronicus, because of chronic rubbing and irritation, the epidermis reactively gets thickened. Epidermis reactively gets thickened. So in LSC, at least the trigger part is not inflammation. Okay, you might have a subclinical inflammation because of chronic scratching, and the lesions get stuck in a vicious cycle, and inflammation leads to thickening, leads to itching, leads to more scratching, leads to more inflammation, and this kind of vicious cycle is there. So in LSC, which shows psoriasiform reaction pattern, it is because of chronic rubbing and irritation, not inflammatory mediated active process of epidermal proliferation. In Bowman's disease, there's increased mitotic activity of component cells. So in Bowman's disease, you have the increased mitotic potential of individual cells. That means the keratinocytes are dividing rapidly, but they are not doing under the influence of inflammatory mediators. They are doing on their own because of the mitotic potential or increased proliferation of individual cells. Okay, so here the inflammation is not increased, just the background proliferation rate of cells are increased. So now we understand that the presence of psoriasiform reaction pattern may not necessarily mean that inflammation is going on. You can see it in LSC or Bowman's disease or even dermatophytes. Okay, and dermatophytic infection, where you in thickened lesions you may be able to appreciate psoriasiform reaction pattern. So let's move forward. So in psoriasiform reaction pattern, we can divide into two parts. We can have the major psoriasiform reaction pattern and then a minor psoriasiform reaction pattern. So in major psoriasiform reaction patterns are those disorders which show psoriasiform reaction pattern as the major finding in biopsy. While in minor psoriasiform disorders, these are those disorders which can or which may or may not show psoriasiform reaction pattern. Okay, so chances of looking at a psoriasiform reaction pattern are more in the major disorders, and these include psoriasis, pustular psoriasis, pityriasis rubra pilaris, parapsoriasis, reactive arthritis, and lichen simplex chronicus. There are other disorders also, but these are the major group of disorders that show the major psoriasiform reaction pattern. In minor psoriasiform disorders, you have subacute dermatitis, erythroderma, mycosis fungoides, chronic dermatophytes, Lichen. And there are other disorders like scabies. They all come into minor psoriasiform disorder. That means those reactions which under certain conditions can show psoriasiform reaction pattern, while the major psoriasiform disorders are those disorders which more often than not will show a psoriasiform reaction pattern. So let's discuss these disorders one by one, starting with the major psoriasiform reaction pattern. So, the histopathological findings in psoriasis depends on the stage at which the biopsy is taken. If there's early stage, that means roughly within 24 hours, all you will appreciate is dilatation and congestion of vessels in the papillary dermis. Now remember, in psoriasis, inflammation is the trigger. So inflammation happens, and because of inflammatory mediators, the epidermis thickens up. Okay, so the first step is inflammation. If you take a biopsy within 24 hours or in an active lesion or even inflamed erythematous lesion of psoriasis and erythematous plaque of psoriasis, the first feature you will see is dilatation and congestion of vessels in the papillary dermis. Okay, there's mild perivascular lymphocytic infiltrate along with edema. So you can see inflammation leading to edema. And what exactly you will see is, let's say this is the biopsy in dermoepidermal junction. Around the capillaries, you will see lymphocytic infiltration. So pericapillary or perivascular lymphocytic infiltration along with edema. So there will be few empty spaces in between. So that is what you are going to appreciate in a very early, less than 24 hours biopsy in psoriasis. There will be some exocytosis of lymphocytes and mild spongiosis. So very mild spongiosis can be appreciated. Not, not the prototypical psoriasiform reaction pattern in early stage, but slowly with time, the reaction will develop. Okay, let's move forward. So here is the early lesion of psoriasiform reaction or the psoriasis, and the appreciable finding is the dilated dermal capillaries. So here we can see they are dilated, stretched out capillaries, very thin layer because the dilatation is significant, and that is the only finding that you may find in an early biopsy of psoriatic plaque. Okay, so let's move forward. So now in the evolving stage, that means the inflammation has gone there, and now you have started having migration of inflammatory cells in the epidermis and thickening of the epidermis. You will see mounds of parakeratosis. Okay, so the multiple areas affected by parakeratosis with neutrophilic exocytosis. Why neutrophil? Because remember, the earliest cell to arrive at a site of inflammation or infection are neutrophils. Gradually, this neutrophilic migration will be replaced by lymphocytic migration. So at the starting, there is focal parakeratosis. So you will see a focal parakeratotic plaque here, black here. But as the inflammation progresses, this can become confluent, okay, a layer of parakeratosis. And this is confluent parakeratosis, confluent neutrophilic parakeratosis. So that means the biopsy is taken from an older lesion. Now, because of this neutrophilic migration, there are abscess formation or collection of neutrophils. If that neutrophils are collected at the level of stratum corneum, okay, at the level of stratum corneum, they are known as Monroe's microabscess. Just remember M from M. So Monroe's microabscess in stratum corneum. But if they are a little bit below, if they're a little bit lower down, then they are known as spongiform pustule of Kogoge or Kogoge pustule. Okay, and they are seen at the level of stratum spinosum. Now, Weedon's mentions stratum spinosum, but I've seen few books mention stratum granulosum. But stratum spinosum should be the preferred term if it's present. Okay, so spongiform pustule of Kogoge is seen in stratum spinosum. Remember, in you might not have a granular layer in a parakeratotic plug in psoriasiform reaction pattern. So mentioning spongiform pustule at the level of granular layer is a bit dicey. A better answer would be that it is present at the level of stratum spinosum. If neutrophils, let me tell you again, if neutrophils are present in at the level of stratum corneum, they are Monroe's microabscess. If they are present at the level of spinosum, S for spinosum, S for spongiform pustule of Kogoge. So just remember that, okay? S to S. Clear? Now, since the epidermis is now proliferating, the underlying granular layer will be absent. There will be epidermal thickness known as acanthosis, dilated and tortuous capillaries, and perivascular inflammatory infiltrate is now more of lymphocytic than neutrophils. Why? Because initially in step 1 there was perivascular neutrophilic infiltrate, but now the neutrophils are migrating inside the epidermis. So they are leaving their position around the vessels to reach the epidermis, and now those empty positions around the vessels will be occupied by lymphocytes. Okay, so in perivascular location, you will have more lymphocytes, while neutrophils are majorly present at the level of epidermis. Clear? Let's move forward. So here we can see psoriasiform hyperplasia. Okay, so step 1, you connect the tips of retipex. You highlight the top of the epidermis. Looks like a parallel line, so there's regular acanthosis. We know that there is thickening of epidermis, so acanthosis is there, and if there are two parallel lines, then it is regular acanthosis, number 1. Number 2, now we'll look for parakeratosis. Here we can see one parakeratosis. Here we can see a parakeratosis. A little bit of parakeratosis here. And you can easily appreciate that this is the granular layer. Okay, so it is not present below the parakeratotic layer. So step number 2 is also complete. Now we'll find out dermal papillary dilatation. Can you see these white spaces? White spaces. This is because of dilatation of dermal capillaries. In fact, here the dermal vessels are getting dilated. So step 3 is done. Step 4 would be to look at the inflammatory infiltrate. So at this magnification, the inflammatory infiltrate will not be easily appreciable, but you can easily see that there is upper dermal infiltrate, and at some areas it is perivascular in location. Okay, so this is perivascular infiltrate, and they are blue color. That means mostly it is lymphocytes and neutrophils combined. Okay, let's move forward and look at the biopsy on a magnified level. So look at this neutrophilic mound, okay, collection of neutrophils. You might find it a bit difficult to differentiate between neutrophilic mound and a parakeratotic mound. Just remember that the nucleus of parakeratosis is inside the corneal layer, inside the corneal cell. So let me tell you what I mean. So here, this is the boundary of a corneal cell, rough boundary. Okay, this is the boundary of the corneal cell, and the nucleus is flattened and it's inside the corneal cell. While here you can see that it is circular and outside, and there are multiple lobules together, and the nucleus is not flattened because this is nothing but a neutrophil. the bilobed or multilobed nucleus of a neutrophil. So this is a neutrophilic mound. Okay, not a parakeratotic mound. Clear? Let's move forward. And here you can appreciate a large neutrophilic mound. Okay, this whole is a parakeratosis along with neutrophilic mound. The top has neutrophilic mound, while this is more of a parakeratotic plug. So we are back to the features of psoriasis, and this slide is there to show the suprapapillary thinning of the epidermis. So over the papilla, there is let me just change the pen. There is suprapapillary thinning. So that can easily be appreciated. And there is suprapapillary spongiosis. So can you appreciate this little, white spaces around white? These are dilated capillaries. You can see capillaries which are large. These are all dilated capillaries and some little bit of spongiosis. So this micrograph is to show you suprapapillary spongiosis and thinning of the epidermis. Let's move forward. So here itself, similarly, you can see the suprapapillary spongiosis. Let me just mark it for you. Here you can see hair, a little bit of hair, but you can easily appreciate regular acanthosis and elongation of retipex. Clear? So I think I've discussed like about 10 slides which show the typical feature of psoriasiform reaction pattern. And now even in 4S, you'll be able to understand that yes, this slide is showing psoriasiform reaction pattern. Let's move forward. If a biopsy is taken from scalp psoriasis, additional features that you will see is sebaceous gland atrophy, decrease in hair follicle size with thinner hair shafts. There's infundibular dilatation, which is a sign of inflammation, and parakeratosis at the infundibular ostia. So if you have like a hair, the parakeratosis will be seen at the shoulder. Okay. So this can be seen in scalp psoriasis, but it's a better feature of Pityriaisis rubra pilaris. There it is known as summit parakeratosis or summit keratosis, but the ostial parakeratosis is seen in psoriasis of the scalp also. Additional features like papillomatosis and scattered apoptotic keratinocytes are also seen. If a biopsy is taken from nail affected by psoriasis, you will see hyperkeratosis, variable neutrophils in the parakeratotic layer, and spongiosis. There's incomplete keratinization. Remember, incomplete keratinization. The epidermal layers are moving so fast that they are not able to mature. And if they are not able to mature, two things happen. The granular layer is not there because it's not formed properly, and the corneal layer will have neutrophils. Sorry, corneal layer will have nucleus, causing parakeratosis. So if the epidermis is dividing so fast that it is not able to mature, you will have hypogranulosis and parakeratosis. If the same thing happens at nail, you will have a subungual parakeratotic scale. That means below the plate, below the nail plate. And that is why you see oil drop signs or pitting in the nail psoriasis. And the nail changes are important because they are the harbinger of early arthritic changes in psoriasis. The features of nail involvement is similar to onychomycosis. So if you receive a nail biopsy, and you are doubtful that fungal elements could be there, it's better to get a past staining, okay, to differentiate. But remember, uh, dermatophytic infection or fungal infection can happen in a psoriatic nail. Okay, in psoriatic nail, the nail plate is thickened. There is subungual hyperkeratosis. Okay, but that makes it more vulnerable for fungal infection. So if you get a biopsy of nail psoriasis and you see fungal bodies, it might be an incidental infection. Okay, so it's better to look at the past staining and see what are the levels of infection. Is it through the all layers or not? Both of the findings or both of the disorders can occur at the same time. You can have onychomycotic nail You can have a psoriatic nail or you can have both of the findings together. So keep that in mind. Okay, let's move forward. In erythrodermic psoriasis, the features of psoriasis are usually lacking. In erythroderma, remember, the whole body is red. Why is it red? Because of superficial vessel dilatation. The blood vessels are dilated. So there are no other features. There's intense inflammation and it is an acute inflammation. It is so quick that the epidermis has not had proper time to react to this inflammation. And because of that, you don't have particular textbook changes of psoriasiform reaction pattern. So features of psoriasis are lacking, but you will see intense dilatation of superficial vessels. Okay, let's move forward. In follicular psoriasis, you will see follicular plugging, marked parakeratosis in the mid zone of the ostium. So remember, in scalp psoriasis, we were looking at the tip of the ostium in fundibular ostia, but now parakeratosis is there in the mid zone of the ostium because the inflammation is arising from the follicle cells, not the skin cells, but the follicle cells. There is paravascular and perifollicular dermal inflammatory infiltrate. Okay, let's move forward. Now, this is the second type of psoriatic this dermatosis or psoriatic reaction, pustular psoriasis. In pustular psoriasis, there is intraepidermal pustules at various stages of development. So this line is important. So there has to be an intraepidermal pustule. Okay. As the lesion gets older, the features are more of psoriasiform hyperplasia. That means there is in pustular psoriasis you have pustules. As we go later in time, the features of psoriasiform hyperplasia are more pronounced. Okay, they are more easily appreciable in a biopsy. Here, the neutrophils they come from papillary dermis. That's where they will come from the blood vessels, and they will migrate to the epidermis. So, migration of neutrophils happens from papillary dermis to the epidermis. So, in short, if this is a biopsy and this is dermoepidermal junction, you will have neutrophils migrating from the superficial dermal vessels. They will migrate to the epidermis, and the epidermis they will form collection, large neutrophilic collection, and this is known as a pustule. And these are the features of pustular psoriasis. So you will have spongiform pustules of Cogos because that's what they are, neutrophilic collection. Okay. In pustular psoriasis, you can see the spongiform pustular cogos, which you usually see at the level of stratum spinosum. You can see them higher up in stratum corneum and upper malphizian layer or upper spinal layer. Okay. So the intense inflammation or intense migration of neutrophils kind of pushes or kind of makes sure that cogos is seen at multiple layers. So in psoriasis, majorly you will see at the level of stratum spinosum. But in pustular psoriasis, it can be seen higher up at the level of stratum corneum. Okay, the same features, that means the intraepidermal pustules, are seen in reactive arthritis or biopsies from reactive arthritis. Similar features are seen. So here you can see the involvement of the upper epidermal layers. Let me just mark it for you. Upper epidermal layer, and this is nothing but neutrophilic collection. You can see that the nucleus is round. It is not flattened. The cells are circular. They are densely packed. So this is all neutrophilic collection. And look at this spongiotic vesicles. These are all filled with neutrophils. Okay, this large collection of neutrophils. In fact, at the perivascular location, you have neutrophils. Okay, so that is what is known as intraepidermal neutrophils seen in pustular psoriasis. Now, in Guttate psoriasis or rapidly evolving psoriasis, okay, the earliest sign is focal mounds of parakeratosis above hypogranulosis, and that is called pinpoint psoriatic papule. So it acts like a psoriatic plaque, but it is pinpoint, okay, like a dot shape, like this. So it is called pinpoint psoriatic papule. And it is nothing but focal parakeratosis above hypogranulosis. Remember, whenever there is abnormal keratinization or the epidermis is dividing so fast that it's not able to keratinize properly, keratinized properly, the granular layer will be absent and there will be parakeratosis. So that is what is happening. In guttate psoriasis, the incident nature is so fast that the cells are not properly keratinized and you have hypogranulosis and parakeratosis. So you have polymorphonuclear cells in the stratum corneum, you have dilated upper dermal blood vessels, and the epidermal changes are more than dermal changes in established lesion. Why? Because it is a rapid onset psoriasis. Okay, let's move forward. So this is of intraepidermal neutrophils, but you can easily appreciate this intraepidermal neutrophils and parakeratotic layer is somewhat less than what we see in pustular psoriasis. Okay, so in pustular psoriasis, you will see intense abscess formation, but in guttate psoriasis, you will see only focal parakeratotic mound. In fact, here also you can see a parakeratotic or the edge of a parakeratotic mound. Okay, and if we remove these markings, you can see that the compact granular layer is somewhat decreasing. It is not that appreciable in this photograph, but the granular layer, now look at here, no granular layer here. There is no granular layer. But here you can see this dark granular layer, stratum granulosum, granular layer. Okay, so there's focal hypogranulosis and overlying hypogranulosis, you have a parakeratotic mound. Let's move forward. Now, these are some essential features differentiating different psoriasiform reaction dermatosis, and I will not explain them in detail because it is just findings that you have to maybe muck up. But if you look at logically, you'll be easily able to understand. Okay, so let's go through it one by one. Parakeratosis is mound-like in gutted psoriasis, like a mountain, like a small hill. Okay. In PLC or pityriasis lichenoides chronica or acute version, it's more of diffuse. It's mound-like again in Pityriaisis rosea, and in secondary syphilis, it's focal. Now, what essentially is difference between focal and mound-like? Mound-like means that there is some height to it. Okay, it's like a hill. It should be like a triangle, like this. It's mound-like. While focal can be flatter also, no issues. It just means intermittent. Focal means intermittent. You have normal skin or normal epidermis in between. Okay, spongiosis is absent, present in PLC, focal in Pityriaisis rosea, and may be present in syphilis. Now, for example, in polymorphs in stratum corneum is seen in guttate psoriasis. Dermal changes, the plasma cells are more prominent in syphilis. So what I will do right now is I'll just mark the important points or the differentiating features. Okay, that would be a bit more helpful. So if you see a lot of plasma cells, think about secondary syphilis or HIV co-infection. If you have polymorphs in stratum corneum, think about guttate psoriasis. If you have more importantly superficial lymphocytic infiltrate, look at the PLC. Okay. If you look at spongiosis, it will be more in Pityriaisis lichenoides, while Pityriaisis rosea is essentially a type of invisible dermatosis. Now, what do you mean by invisible dermatosis? Invisible dermatosis are those diseases which you can see clinically, but when you take a biopsy from them, you don't see very specific features to make a good diagnosis. It's mostly descriptive. So in Pityriaisis rosea, you will actually appreciate that nearly all features are very non-specific. Okay, so I'll just remove all the markings. If you want, you can take a screenshot, and this kind of summarizes the features seen or differentiates between different type of psoriasiform tissue reaction pattern. Okay. So I hope you have taken a screenshot. Let's move forward. Now coming to the next disorder, Pityriaisis rubra pilaris. So from henceforth we'll go faster because we have spent at least 40 minutes understanding what is psoriasiform reaction pattern, and now we'll go faster. We'll just look at the basic changes. Okay. In PRP, biopsy should be taken from an erythematous area. That is a better chances. Okay. There's irregular acanthosis, hypogranulosis, mild spongiosis. There's alternating orthokeratosis and parakeratosis in both vertical and horizontal direction, and this is known as the checkerboard pattern. What is checkerboard? Checkerboard pattern. I'll add an image of checkerboard here, or you can just imagine chess. Okay, verified diagram. I'll add an image. Don't worry. So here you can see this alternating, black and white squares. So this is, for example, let's say black square is parakeratosis, white is orthokeratosis. So you have alternating ortho and parakeratosis horizontally. You have alternating ortho and parakeratosis vertically. So that is known as checkerboard pattern. There is collarate around the follicular ostia, which is known as shouldering or summit parakeratosis. Okay, so again, if you have a hair follicle, parakeratosis is seen at the shoulders. And that is why you have scaly follicular plaques. Remember, parakeratosis means scaling. Okay, let's move forward. There's follicular plugging. If the scales are too much in number or too much in quantity, the follicle gets plugged in. There's superficial perivascular and perifollicular lymphocytic infiltrate. And in some cases, you can see lichenoid reaction. Okay, so here you can see alternating. Let me just mark it for you. So this area is orthokeratosis. Okay, while the adjacent area is parakeratosis. Okay, this adjacent area is again parakeratosis, orthokeratosis, parakeratosis, orthokeratosis. Clear? So you can appreciate that it is alternating in this direction. Let's get rid of the markings. Now, this area is parakeratotic, this area is orthokeratotic, this area is parakeratotic, this area is orthokeratotic. So, orthokeratosis, parakeratosis, orthokeratosis, parakeratosis. You can see nucleus is present, not present, present, not present. This is darkly stained, light stained, dark stained, light stained. So, it is alternating in this direction also. And that is why it is checkerboard pattern. Clear? So there's alternating ortho and parakeratosis in both direction, vertical and horizontal. Let's move forward. And this is a follicular plug here, follicular plug. And in fact, you will be able to appreciate a little bit of parakeratosis here at the shoulders. You can see it's a more blue stain because of the nucleus. So parakeratosis at the shoulder. Let's move forward. Now coming to the next disorder is Lichen simplex chronicus. In Lichen simplex chronicus, remember the clinical lesion. The clinical lesion is an ill-defined thick plaque, okay? An ill-defined thick plaque, agreed? So there's thick layer of compact orthokeratosis with overlying hypogranulosis, focal parakeratosis, and irregular acanthosis. Now this term is different from psoriasiform hyperplasia. Remember, in psoriasiform hyperplasia, you see regular acanthosis, okay? While here you're looking at irregular acanthosis. The epidermal thickness and volume are greater than in psoriasis because the lesion itself is thicker than what we see in psoriasis. There is vertical collagen fibers, and this we see when there is scarring or fibrosis due to chronic irritation. So vertical presence of collagen fibers is because of scarring and fibrosis due to irritation. If LSC is present over scalp, two signs have been described. You have the gear wheel sign and the hamburger sign. In gear wheel sign, you have jagged acanthotic projections of the outer root sheath. So what essentially happens is you have a hair follicle and the outer root sheath shows projections, acanthotic projections. So it looks like a gear wheel, okay? Like you have that machine gears. Okay, so it looks like gear wheel. Very bad diagram. Just give me a second. So you have this kind of machine gears. So that is known as gear wheel sign. In hamburger sign, The hair shaft is split into two segments. So you have a hair shaft and it gets split into two segments because of RBCs. And this looks like a burger. So this is an hamburger sign. Okay, let me show you some photographs. So this is the gear wheel sign. So if you want to look that in detail, you can visit this article. I'll provide the link in the description so you can go and read about it. So can you see this is the outer root sheath cell? And there are projections. This is one projection, projection. Okay. So this kind of acanthosis of the outer root sheath cell, sorry, outer root sheath layer is what is known as gear wheel sign. Okay. Let's move forward. This is the hamburger sign. So the hair shaft, this is the hair shaft. Okay. Hair shaft. And this is because of the proliferation or the migration of neutrophils, sorry, RBCs. And if RBCs are getting inside it, it splits the hair shaft into two parts. And these two parts look like buns in a burger. And this looks like the filling. And that is why it is known as hamburger sign. Okay, so let me remove the marking so you can now appreciate the hamburger sign. Clear? Let's move forward. So this histomicrograph shows you a very thickened epidermis. Okay, so can you make you can easily make out the thickened acanthosis. Okay, so thickened epidermis. There's intense parakeratosis. There is hypogranulosis. Here you can see the granular layer is essentially absent. Here it is present to some extent. And wherever it is absent, that is where you see major thickness of the corneal layer. So you have hyperkeratosis, you have orthohyperkeratosis, you have a little bit of parakeratosis here. Okay, let me remove the markings. So you have a parakeratosis here, you have increased thickening of the epidermis, which is irregular. So you have a broad irregular acanthosis, and you can appreciate a bit of sclerosis in the dermis. We'll see it in details in the next slide. So here, can you appreciate that if you draw a line here, you might miss certain areas of retipex because it is irregular. All the retipex are not uniform in length. You go back to this same video and you'll appreciate that slice showing psoriasiform reaction pattern had a regular elongation of retipex, while in LSC, the elongation is not regular. It's at different levels. So we can see broad acanthosis, that means a very thick epidermis, but the length of retipex are irregular. There is sclerosis. So can you see this light pinkish area? All the light pink area is just increased fibrocytic activity and sclerosis. So there is sclerosis with broad acanthosis. Additional features that you can appreciate here is vertical orientation of capillaries. Okay. Can you appreciate the flattened capillaries? They are so flat and they are vertically oriented. Can you see these features? If this feature is present, it is present because of sclerosis, because of intense scarring or intense fibrosis. It is stretching the capillaries to form a very thin slit-like vertical capillaries, and that is a very important feature of LSC. Let's move forward. So this is again a magnified version of the same slide, and you can appreciate this kind of vertical fibrillary or vertical fiber-like, wire-like pink-colored collagen. So this is collagen which is arranged vertically. Okay, and that is why the capillaries are also stretched vertically. This you see in disorders which have a lot of scratching and chronic irritation. And in this magnification, you can easily appreciate hypogranulosis with parakeratosis. With parakeratosis, again hypogranulosis. Okay, dilated capillaries. Let's move forward. So this table differentiates the histopathological features of psoriasis and LSC. The parakeratosis is patchy in psoriasis, while it is diffuse in LSC. The suprapapillary epidermis is thinning. Remember, multiple slides I showed you that above the papillary epidermis is thinned out, while in LSC it is thickened. Okay. Spongios is absent, but there can be a small foci present. In fact, here also a small foci can be present, but mostly spongios is seen in LSC. Monroe's microabscess and Cogo's pustules are both features of psoriasis. They are not seen in LSC. Reticles are regular. They are regularly enlarged or regularly elongated, while in LSC it is irregular. The vessels are dilated and tortuous because capillary proliferation is happening. Why it is happening? Because of inflammatory mediators. While in LSC, there is no inflammatory mediators, so they are just dilated. Collagen are seen as linear bands, while in LSC, they are vertically oriented. So I showed you the vertically oriented collagen fibers, isn't it? So vertical oriented collagen fibers are features of LSC. So this is an algorithm to kind of guide you while looking at a slide showing psoriasis hyperplasia. I've taken it from Fundamentals of Pathology of Skin, page 95. So if you have the book, you can go through it. So you see a slide which shows psoriasiform hyperplasia. Okay, you have understood, you have gone through the 4x magnification, and now you see the epidermis. If there are polymorphs or majorly the neutrophils are there in epidermis, or there are no neutrophils in epidermis. If the neutrophils are there and they are forming Monroe's abscess, then it is mostly, more often than not, psoriasis. If it is showing sandwich sign, now what is sandwich sign? That you have normal skin, then you have newts, and then you have normal skin in the epidermis. So like a sandwich. And that is seen in dermatophytosis or skin fungal infections. Okay. And if you see follicular polymorphs, that means aggregated around the follicles, think of seborrheic dermatitis and try to find out other features. We are clear about it? Let's move forward at what happens that you have psoriasiform tissue reaction pattern, but you don't have neutrophils in the epidermis. So if you don't have neutrophils in the epidermis, you see mite in the stratum corneum, you think about scabies. Okay. You have spongiosis, you think about chronic dermatitis. You have vertical collagen bundles like we saw in the slide, you think about LSC. You have vertical parakeratosis and a checkerboard pattern, you think about PRP. You have mound-like parakeratosis, you think about parapsoriasis. If you have multiple plasma cells, think about secondary syphilis or HIV co-infection. Okay, so just to guide you how to move forward while analyzing a slide showing psoriasiform hyperplasia. Okay, so with that, the reading recommendations are two books: IADVL textbook of dermatopathology and the fundamentals of pathology of skin. Plus, look at a lot of slides, read a lot of biopsy reports, go to pathology outline. It's a very good resource to learn about histological features. Okay. The further reading includes Weedon's Fundamentals of the Skin, IADVL textbook, Pathology Outlines, Mckee's Dermatopathology, and these few articles that I read about showing hamburger sign and gear sign. I've just mentioned it. I'll put the link in the description. You can copy paste and read the full article. So with that, I'll finish this week's lecture, and it's a long lecture, so I will not take much of your time. Any comments can be mailed to me, or you can just mention them in the comment section. Any doubts, suggestions, make sure that you mention the timestamp so that I can know in what context you are asking the doubt. I may know exactly what the topic is going, so that whatever question you're asking, I'll be able to understand it and then answer it better. Without much further ado, adios and bye bye. We'll meet again next week with the next reaction pattern. Bye.